This lady, she asked me, she's concerned with the lack of volume in the anterior malar area. Would you smile for me, please? No, let's wait for the screen. She has a normal lateral volume, which not a lot, but she doesn't feel like being too much filled. There is a normal asymmetry of a face, which is more marked here on the zygoma on the right side, certain degree of asymmetry of her chin, which in the profile has some retrusion, but in the vertical dimension it's all right. So if she needs something, it would be just bringing it forward. She has a strong mentalis muscle, and if she'd been my patient, she would have been injected a week previously with some botulinum toxin in the mentalis to release that contracture, which would have helped to bring it forward. She also asked me if we could do something for her nose and anterior nasal spine, but we don't have much time today, unfortunately, to do that. So I will just inject her in this area, and I hope I'll be able to demonstrate that injecting at the bone level allows for getting a lot of volumizing effect with little product, which is very interesting because then it's less costly for the patient and it's better for us because I'm getting old and I'm getting lazy and I don't want to inject 5, 6, 7, 10 syringes when I can manage to have the same results with 2 or 3. Okay, so you can see the lack of volume in this area. You can appreciate it on the 3/4 because you see that here it's not very marked, and the hollowing there. Okay, this is the tetraph, and here is more of a malar groove. Can you smile? But you see the volume here is okay. The lack is here. So there's no point to inject within the skin. Thank you. So this would be the area where she would need some volume. I would start with the lower part of her malar because this is the key point between the roundness of this and the fullness of this other compartment here. Okay? So when you get a marked nasolabial fold, it's because this is falling down. Okay? So what we want to do is compensate for the volume loss. In her case, she's young, she has very little volume loss, but she's lacking of bone base. But then, if this is the problem, the simple fact to lift up here will improve the global aspect of the nasolabial fold. And if it's not enough, then the idea would be not to pull the skin like that, because that doesn't change in depth. Where are the changes? But I would address the fat with some threads, but in the fat here, to lift that up and not the skin, which is also a physiological error, although it is widely publicized for many reasons by the manufacturers. We are doctors, and I always say don't believe the lab. Watch what we do and how we do it. Now we have to be careful because the deepest part here corresponds to the emergency, to the suborbital nerve, okay, emerging point, and the suborbital foramen, which is just there. So we have to avoid that, and so injection will be along that line, and then eventually in this area here, if we can manage that, okay? And then at the chin level, I will see how I can compensate for this from the midline, a little more on one side than on the other, and you can see the groove when she contracts her muscle. Okay, so ideally, I like to work with my patients sitting up as much as possible, but this table is not really good for that. But it's not the table that makes the difference. So, are you okay like that? You don't mind having... Okay, right. So I will start with this. Just a small point, right down to the bone, touching the bone, lifting up, and you have to avoid to scratch too much the periosteum because it is a very sensitive membrane. The product is not painful. You touch the bone gently. and I lift up a little, and I maintain my needle in position with my left hand, which doesn't touch the skin really. And I will inject probably 0.1 of a milliliter, and that should be enough to start very gently, to start lifting up this area. And now I can build up from there. Another point, just above here, I have to be perpendicular to the bone and stay away from my suborbital nerve. So the orientation, I will try not to hide the camera, my injecting direction will be like that, away from this point. All right? You're okay? I'm sorry to hide it, but I'm right-handed and I can't. So I will inject 0.1 here of a milliliter, maybe 0.15. Okay. And then I will finish up right by a third point there. I can feel where our orbital ridge is, rim, and we'll inject just a tiny amount there, still perpendicular. I could do that with a cat. Oops, sorry. Okay? Is that all right here? Okay? Are you all right? So, nice thing with the needle and is that when you touch a vessel, which probably was the case deep down there, it's very painful. So in that case, you just have to retrieve your needle and push slightly laterally. Okay. All right. Yes, please. Are you okay? Any pain? No? It's gone? Yeah, okay. I will change the needle because after a few touching of the bone, of course, it scratches. And thank you. So I need a little more in there. I don't know if you can see it. A little more up there. So I will put another point here and inject another 0.1. Would you sit up, please? Sit up. Now, you can see the difference between the two sides. She really lacks volume here, and we have to be very careful. Yeah, I need a little more there, but I don't want to get too close to the suborbital nerve. And so what I will do is just go from there, just here, and inject another 0.1. Okay? Now, can you see the difference between the two sides? Okay, between the hollow that we have here and the fullness, smile. And you see there is no ball appearance. You get this ball appearance when you inject below the skin, because then it will lift up. Because when you smile, what do you get? You get a repositioning of the deep fat. And if you have added a volume on top of it, then you end up with terrible balls, like you see in all these poor ladies on the TV and magazines and everywhere. And you can see that her tetraph has been improved without injecting anything inside, okay? And are you all right? You can also see that their nasolabial fold was not very marked, but has totally disappeared. Okay? Right, down you go. And I will just finish, I've used 0.9 altogether, so you see it's very little. And I will finish with the last 0.1 down here. There are two ways there. Either you go right down to the bone, this is when you want to lift up the alar base, or what I very often do in that case, if I want to have the lock, is to stay fairly superficial. So I go perpendicular to the skin, but then I stay in the hypodermis. I'm just below the dermis, and I move like that, and I see that I'm in a safe plane, and she's not complaining of any pain, which would be the case if I had, like here, touched a small vein. So, this is 1 mil for one side, And then I can do the same on the other side. Okay? So she needs less on this side, we've seen that before, but nevertheless I start with the same key point down there, lowest part of the malar bone, small injection, small amount there, 0.1 in that side would be enough. From there I could build it up with a cannula. The technique is just a tool. Okay, I don't see I need 2, 5, 25 points and special landmarks. Every patient has a different face. Every patient has to be treated differently. The only landmark I keep are the ones in the depth and the changes in the volume. Okay, so I will try from there just to try to avoid what happened on the other side and just give a tiny 0.1 of a milliliter up there. Okay, and avoid the superficial vein I got from the other side. And a last point, just there. Okay? Very, very small amount. With this product, you immediately see the lifting up, so you don't need to inject much. And I will do the same at the nasolabial fold, injecting here, aiming towards the elbow base, never up there, because this is where you might encounter some unpleasant vessel. All right? Pain is the first sign of vascular effraction. But if you stay in the hypodermis, there are no nerves endings in the subdermal fat. It's totally pain-free. So if it's painful, either you touch a vessel or you're not in the proper plane. Would you sit up for me, please? Can you see the difference now from how she was before? I need something to wipe this off. And there's a slight difference in volume in both sides because she lacks from small volume here, which I'm going to inject. Okay? It's okay. Yeah. Yes. So I always keep a wet swab in my hand with chlorhexidine. How is that? Okay? So you know that you can't rely just on your personal knowledge of anatomy because the facial artery course is different from one individual to the other. It's also different from one side to the other. So we have to be careful all the time about that. No, not yet. I need tiny, tiny amount there, but I'm really concerned about the suborbital nerve. And I will see if it's just like a tent. If you put the pole on the proper position, the whole tent will lift up. Okay? So it's not a question to flow the area. It's really a question to lift up the points that need to be lifted. So this is 1 ml per side, and I will use my last syringe to do the chin for anterior projection. So she has a fairly high chin, so I really want to be anterior. So we'll start with the midline. Okay. Injecting 0.2. I never inject more than 0.2 in any point because I want absolutely to avoid getting nodules. Nodules are completely different from granulomas. A granuloma is an acute inflammation, strong inflammation, whereas a nodule is a reaction from the tension within the tissues. You know that tension in the tissues is regulated by the fibrocytes, because the fibrocytes, they have small fibrils which are inside the cytoplasm, which are in continuity with the same very small fibrils that prolong the collagen type 1 fibers. So there is a functional unit between collagen type 1 and fibrocytes. And if there is too much tension in the tissues, then the fibrocytes are informed, they get the information, and then they will send a signal to produce collagenase to break the collagen fibers. If there is not enough tension, then they send a signal for fibroblasts to create new collagen. But if there is too much tension because of a foreign body, or a breast implant, or whatever, then collagenase is inefficient. You start by encapsulating your foreign body with collagen type 3, but collagen type 3 cannot be dissolved by collagenase, and that's a good thing, otherwise we wouldn't have wound healing or protection. So what happens? Well, collagenase is inefficient. The body wants to defend itself. What does it do? Fibroblasts transform themselves into myofibroblasts. And then they create myofibrils. And the aim of these myofibrils is to contract the surrounding tissues, not the capsule. The capsule doesn't change. It's proper fibrous tissue with 90% collagen type 3 and 10–15% collagen type 1. Like any scar, like Dupuytren's disease, it's normal collagen, does not retract. But it's the attraction of the surrounding tissues to concentrate the tension in one point and release the tension around. This is a nodule. So it's a very different situation. So, where am I here? Would you please sit up? Okay. And profile, I have a slight augmentation, frontward. Doesn't show too well here. I didn't augment down there. I just projected it a little bit there. And there is still a small asymmetry in this area. And this will be the end of my injection of my third syringe. So you see, with 3 syringes, with just 3 mils, I've been able to fill up our malar, to correct our beginning of nasolabial fold, and to improve and modify the volume of our chin. So you don't need a lot of product. And the results here, I think it's élancé S or M? S. Élancé S means that the microspheres will stay for a year. It will take 3 months for the total collagen to be completed. It takes 4 weeks for full encapsulation, and then you have to wait 3 months. And then during that time, you get more volume because of the size, as I said, the volume of the collagen fibers. So she's young, and you might expect at least 30% increase of the volume she's got. 30% in 0.1 or 0.2 of a milliliter is very, very little. And if it had not been measured by very precise measurement in 3-dimensional cameras, then we would not, I never appreciated that before. But now I know this is one of the reasons why our results will last far more than the year of the duration of the microspheres. At least a year and a half, more probably 2 years, as you have seen on the examples I've showed you on the lips or on the chin, on the cheeks. Sorry. Thank you very much. Any questions? She's been a perfect patient. She didn't cry, she didn't bite me. It was very nice. Thank you. What do you need? No, that's it.
Any questions from the audience?
The product is not painful. You don't have to mix it. You should not dilute it. Mixing means that you can go up to 20% of lidocaine, which is 0.2 of a milliliter for a syringe, for 2 reasons. The first one is if you go over 30%, then you change. It's no longer a medical device. It becomes a drug. It's not the same regulation. No product on the market, injectable product, have more than 30% lidocaine. And the second is that above 20%, it's been studied by the laboratory, you change the physical properties and it's a different product. And especially in terms of risk of clustering of the microspheres. And this clustering, the clusters will create a reaction as if it were a large volume. And this bolus can start a nodule reaction. So no diluting of the product, mixing maximum 20%. Okay? Thank you.